In the next section, we'll be examining the pancreas in greater detail and discussing aberrations in the normal physiological processes. In this section of the GI physiology module, we'll be looking at the pancreas and disorders of the pancreas. The first diagram is an overview of the anatomy of the liver, the gallbladder, and the pancreas. Points to note are the drainage of the pancreatic duct into the duodenum and of the common bile duct into the duodenum. The importance of this will become evident later on in this talk. As we mentioned in the peptide and hormones section of this module, acinar cells in the pancreas, upon stimulation by cholecystokinin, secrete enzymes to digest carbohydrates. This enzyme is pancreatic amylase. They also release enzymes to digest lipids. These are pancreatic lipase, colipase, phospholipase A2, which is activated by trypsin, and cholesterol ester hydrolase. They also secrete enzymes to digest nucleic acids, namely deoxyribonuclease and ribonuclease. Therefore, stimulation of the pancreas by cholecystokinin is important for causing release of enzymes which are pivotal in digesting food once it's entered the duodenum. Trypsinogen is activated to trypsin by entropeptidase or enterokinase, and then autocatalysis can subsequently take place with autoactivation of trypsinogen to trypsin. Trypsin is also important as it causes the activation of proenzymes chymotrypsinogen, proelastase, procarboxypeptidase A, and procarboxypeptidase B into the active forms of the enzymes. Just like salivary gland secretion, acinar cells in the pancreas are important in secretion, and in the same way as with salivary glands, secretion into the acinus is isotonic. With passage through the ducts, bicarbonate is secreted and chloride is absorbed. At high flow rates, secretion stimulates increased bicarb-chloride exchange, resulting in increased amounts of bicarbonate in pancreatic secretions. This finding is explained by the fact that pancreatic ductal cells have carbonic anhydrase. They are therefore able to generate H+ and bicarbonate. With secretion, bicarbonate and chloride are exchanged for each other, resulting in increased bicarbonate content of the pancreatic secretion. This is another reason why secretin is important and is associated with increased bicarbonate production from the pancreas. There are multiple phases that control pancreatic secretion. There is the cephalic phase, which is similar to those for gastric stimulation via vagal efferents. The gastric phase occurs with distension stimulated via the vasovagal reflex. The important thing about these two phases is to understand that the pancreatic phase does not begin when food contents enter the small bowel. These phases are present as soon as food enters the oral cavity and digestion begins at that time. This is a cascade that occurs throughout the body, which is then potentiated when food enters the small bowel. In the intestinal phase, amino acids, small peptides, fatty acids stimulate the eye cells, as we mentioned earlier, in the intestine to secrete CCK or cholecystokinin. CCK secretes pancreatic enzyme secretion from acinar cells. This is mediated by IP3 and the calcium secondary messenger system. As we mentioned earlier, CCK results in the release of pancreatic amylase, pancreatic lipase, colipase, and also enzymes that digest nucleic acids such as deoxyribonuclease. Acetylcholine also stimulates acinar cell secretion. Low pH or acid stimulates S cells in the duodenum to secrete secretin. and this stimulates ductal cells to secrete bicarbonate. As we mentioned earlier, in the presence of high levels of secretin, bicarbonate is exchanged for chloride, resulting in bicarbonate-rich fluid. CCK augments the effect of secretin, and this is an example of two enzymes working together to potentiate the effect of one of them. The next diagram really shows a good overview of the regulation of pancreatic secretion. On the left-hand side, as you look at the screen, phenylalanine, methionine, and tryptophan, as well as small peptides and fatty acids, act on the eye cells in the duodenum and result in release of cholecystokinin. Via secondary messenger systems, namely IP3, this results in enzymes which cause digestion of proteins, lipids, and nucleic acids. Acetylcholine potentiates this effect. On the right-hand side of the screen, we show that acid or low pH stimulates S cells to secrete secretin. Via cyclic AMP, it causes ductal cells to release fluid that is rich in bicarbonate. Again, acetylcholine and cholecystokinin potentiate this effect of secretin. Often in a physiological situation, as food is being digested, cholecystokinin and secretin will be secreted together, and so cholecystokinin often acts as a potentiator for secretin-mediated production of bicarbonate. Pancreatic insufficiency is an important topic because it's often seen clinically. The causes are legion, and we will go into some of these today. This occurs when pancreatic enzymes which are present and hydrolyzed triglyceride to monoglyceride and fatty acids do not function in the normal manner for different reasons. In adults, this is most often caused by chronic pancreatitis due to alcohol. This may result in decreased production of pancreatic enzymes, or in children this is caused by cystic fibrosis, where the release of these enzymes is impaired. Maldigestion of fats occurs due to diminished lipase activity, and therefore undigested fats and fat droplets are found in the stool. Protein maldigestion occurs because trypsin is not released, and undigested meat fibers are found in the stool. Carbohydrate digestion, however, is not affected. This is important because amylase, which is present in the salivary gland, still has 30% activity, and brush border enzymes can help to digest oligosaccharides, and we will go into some of these in greater detail later on in this section. Bile salts and bile acids are important because they micellarize monoglycerides and fatty acids. What this essentially means is that they package these fatty acids for absorption. If this micellarization cannot take place, absorption is impaired. Pancreatic insufficiency can be caused by inadequate production of bile salts or acids from cholesterol, such as in cirrhosis. When there's intrahepatic or extrahepatic blockage of bile, this can occur in primary biliary cirrhosis, or if there's a stone in the common bile duct impairing release of bile from the gallbladder. This can often present with pain because cholecystokinin will stimulate secretion of the gallbladder, and if release of biliary bile salts does not occur, there's increased pressure in the gallbladder and cause pain. Bacterial overgrowth in the small bowel can result in destruction of bile salts, and therefore micellarization cannot take place, and there's subsequently malabsorption. Drugs such as cholestyramine can cause excess binding of bile salts and prevent absorption. And if there's terminal ileal disease which prevents recycling of bile salts and acids, this occurs typically in Crohn's disease, which is most commonly found in the terminal ileum. If there's inflammation of the terminal ileum, or resection has had to take place due to stricture formation, recycling of bile salts does not occur, and therefore insufficiency is present. Another important thing associated with the pancreas is pancreatitis, or inflammation of the pancreas. Clinically, this is an incredibly important scenario, as because if it's not managed correctly, it can result in death. There are two types of pancreatitis: acute pancreatitis, which can be interstitial or necrotizing, and chronic pancreatitis, which is associated with pancreatic pseudocysts and with pancreatic insufficiency. Acute pancreatitis occurs when there's activation of pancreatic enzymes with autodigestion. Everyone has their own mnemonic for acute pancreatitis, but the list of causes to remember include alcohol abuse, gallstones, hypercalcemia, hypertriglyceridemia. Things that are easily tested are drugs that cause acute pancreatitis, and these include azathioprine, pentamidine, and hydrochlorothiazide. Infections such as mumps, Coxsackie, and parasites can also cause acute pancreatitis. There can be iatrogenic causes, such as after an ERCP, when pancreatitis occurs because the pancreatic duct has been cannulated or dye has been secreted into the pancreatic duct, and with blunt trauma to the abdomen. There are also vascular causes when there's ischemia of the pancreas for any reason, and this can be seen in vasculitides such as SLE. Miscellaneous causes that are important to remember include cystic fibrosis. A penetrating duodenal ulcer, as we mentioned earlier, can erode into the pancreas and cause acute pancreatitis as well. Clinically, patients will classically present with epigastric pain that radiates round to the back. It's associated with a low-grade fever, nausea, and vomiting. And patients can sequester large volumes of fluid in their abdomen as inflammation takes place. Therefore present with tachycardia, orthostasis, and ileus, which is a reaction to the inflammation in the abdomen. Two classic signs associated with acute pancreatitis are Cullen's sign, which is discoloration around the umbilicus, and Gray-Turner's sign, which is present in the flanks and suggests hemoperitoneum or retroperitoneal hemorrhage. Gray-Turner's sign is also seen with rupture of aortic aneurysms in the abdomen. Lab testing for acute pancreatitis includes checking serum amylase and lipase. Levels of these do not correlate with severity. Amylase and lipase can be elevated in renal failure, and perforation of any viscus can cause an elevation in these enzymes. Serum liver function tests can be abnormal, and if associated with an elevation of alkaline phosphatase or gamma-glutamyl transferase, may suggest gallstone pancreatitis. Imaging studies include an abdominal X-ray or chest X-ray, which includes the classic sentinel loop, which is essentially a paralyzed loop of bowel with ileus present, a pleural effusion, or ARDS. A CT scan is useful for evaluation of complications and is normal in 30% of cases. It's especially useful when looking for necrotizing pancreatitis, which carries a much higher mortality with it. ERCP is reserved for therapeutic interventions, and increasingly MRCP is used, as this is a non-invasive study and can be used as a diagnostic tool without exposing patients to the risk of ERCP, which include pancreatitis. Ranson's criteria for acute pancreatitis were developed a number of years ago to try and stratify patients with acute pancreatitis. The problem with Ranson's criteria is that they are prospective and do not allow accurate stratification upon admission of a patient. On admission, criteria that are used are age greater than 55 years, a white cell count greater than 16,000 per millimeter cubed, a glucose of greater than 200, an LDH of greater than 350, and an AST above 250. Within 48 hours, if there's a hematocrit drop of 10%, a BUN rise of 5 mg per deciliter, a calcium less than 8, a PO2 of less than 60, a base deficit of greater than 4 milliequivalents per liter, and a fluid requirement of greater than 6 liters, these are all negative prognostic signs. Fulfillment of 3 or more criteria of 48 hours indicates severe disease. Greater than 3 risk factors has a mortality rate of 15%, and greater than 6 risk factors has a mortality rate of 100%. Management of acute pancreatitis is essentially supportive. This includes bowel rest initially, but early feeding if the clinical scenario allows. Intravenous fluid, as large volumes of fluid are sequestered in the bowel, and analgesia for pain caused by inflammation. Empiric antibiotic therapy used to be recommended for necrotizing pancreatitis, but if necrotizing pancreatitis is present in the setting of fever, then antibiotics should be used. The antibiotic of choice is IV imipenem. Parenteral nutrition versus post and pulmonary feeding should be tried if the situation allows, if there's a stone in the pancreatic duct, ERCP may be indicated. If there are infected pancreatic collections, drainage may be required, and if there are necrotic areas of the pancreas, then a necrosectomy, which is a high-risk operation, may also be carried out. Complications of acute pancreatitis include a local phlegmon. This represents an ill-defined inflammatory fluid collection which should be sterile. There are pseudocysts with defined non-epithelial walls. Pancreatic abscesses when there are collections that have become infected, and hemorrhage from pseudoaneurysm of the splenic artery. This is otherwise known as hemosuccus pancreaticus and is an unusual cause of an upper or lower GI bleed. Systemic complications of acute pancreatitis include ARDS, pleural effusions, and atelectasis. There is also renal failure associated with acute pancreatitis and often occurs because of intravascular volume depletion. Shock and dehydration may occur for the same reason, and when multi-organ failure is developing, DIC may also occur. Chronic pancreatitis, on the other hand, represents persistent inflammation of the pancreas with irreversible damage and histological changes. This is associated with loss of both the endocrine and exocrine function of the pancreas. Patients can therefore present with diabetes as well as malabsorption. The cardinal symptom in these patients is recurrent abdominal pain. The classic triad that is often seen is pancreatic calcifications, steatorrhea, and diabetes mellitus. Due to malabsorption, weight loss and malnutrition is often seen in these patients. Chronic pancreatitis is most commonly caused in the Western world by alcohol abuse and is directly correlated with the amount and duration of alcohol use. It's seen in children with cystic fibrosis, as there's gradual destruction of the pancreas, and malnutrition is the most common cause in developing countries. The next diagram shows a pancreatic pseudocyst. This is essentially can be of two types, and the non-communicating type or a communicating type. And the CT scan shows a large pseudocyst with pancreatic calcifications. The pseudocyst can be seen as the large round circular collection, and the pseudocyst is at around 4 o'clock to the collection itself, and that represents pancreatic calcifications. This is characteristic of chronic pancreatitis, as this calcification takes a long time to occur. In the last section, we discussed the normal physiology of the pancreas, as well as disorders such as acute pancreatitis. Both of these are important to know well because they represent a rich area of material for examiners to test.